Hello and welcome to HSE Antibiotic Prescribing Aligned series. Let us discuss one of the common conditions we face in primary care and out of hours.
Please note that this video is for educational purposes only, and your clinical decisions are your own responsibility.
Hello and welcome to HSE Antibiotic Prescribing Aligned series by Dr. Wala Eldin. Let us discuss one of the common conditions we may face in primary care and out of hours.
It's fantastic to be here, and honestly, describing this condition as common might be the understatement of the year.
Right.
If you are working in general practice, an urgent care shift, you are going to see this. You've probably seen it this morning.
Oh, absolutely. It is the bread and butter of acute presentations. We are talking about ear pain. It sounds so simple, doesn't it?
Mm-hmm.
Just an earache. We often call it swimmer's ear or, the proper label, acute otitis externa. But the pain can be completely out of proportion to what you actually see.
That's a great point right off the bat. The pain intensity is a real hallmark. But the reason we're doing a deep dive today isn't just because it hurts. It's because it's surprisingly easy to, get complacent with it.
Yeah, you fall into a routine.
Exactly. See a red ear, prescribe drops, next patient. But today we are slowing down. We're looking at the HSE Antibiotic Prescribing Guidelines for Community Settings, specifically the Acute Otitis Externa section from July 2022.
And the goal isn't just to read off a drug list. Anyone can do that.
Right. The mission today is to really dissect these guidelines to understand not just what to prescribe, but how to make sure it actually works. Because there's nothing more frustrating than having that patient bounce back 72 hours later.
In even more pain.
We want to stop that bounce back loop.
So let's get into it. We've got the HSE guidelines here. Before we talk prescriptions, we need to be really precise about what we're treating. How does the HSE define this?
So strictly speaking, acute otitis externa is defined as cellulitis. It's cellulitis involving the skin of the ear canal. That's the core of it.
Okay, so it's a skin infection.
It's a skin infection. And the guidelines are very specific about the time frame. We're talking about inflammation and symptoms lasting less than 6 weeks.
Less than 6 weeks. That feels like a generous window for acute. Most people are climbing the walls after a couple of days.
They usually are, yeah. But that cutoff really matters, because if someone comes in and says this has been bothering them for, say, 3 or 4 months.
Stop right there.
You're in a totally different territory. That would be chronic otitis externa.
Right.
And that's a whole different beast, often driven by allergies, fungal infections, maybe diabetes. The drops we're discussing today just aren't going to fix that.
Okay, so we're ruling out the chronic cases. What about the other end of the spectrum? The really scary stuff.
You mean malignant otitis externa?
That's the one. The name alone is terrifying.
It is, and for good reason. It's not malignant like cancer, but it's an aggressive, life-threatening infection. Basically, osteomyelitis of the temporal bone. It eats into the skull base.
So that's an immediate hospital admission.
Urgent referral, IV antibiotics, the works. So for today, we're staying firmly in the lane of the acute, uncomplicated bacterial infection.
Got it. So speaking of bacteria, who are the usual culprits here?
It's usually a 2-horse race. You're looking at Pseudomonas aeruginosa or Staphylococcus aureus.
Okay.
And that matters because Pseudomonas in particular loves water, it loves moist environments, and it can be pretty resistant to a lot of common fungal antibiotics.
So let's talk diagnosis. In a busy clinic, what are the classic signs that just scream otitis externa?
The first thing to look for is the speed. The guidelines highlight rapid onset as a key symptom. We're talking ear pain that ramps up in less than 48 hours.
So they're fine 1 minute, agony the next.
Pretty much. Along with that, you'll see the classic lineup. Otorrhea, that's discharge from the ear oral fullness. Itching is a big one early on, and often some decreased hearing.
And is that decreased hearing from nerve damage or something else?
No, in the acute phase, it's usually just mechanical. The canal is swollen shut or full of gunk, so sound waves just can't get through.
Right.
But there is one symptom that I find really, really helpful. They call it the chewing sign.
The chewing sign. You mean it literally hurts them to eat?
Yes. Pain that is significantly worse with jaw movement.
Why is that? What's the connection?
It's just anatomy. The ear canal sits right next to the temporomandibular joint, the TMJ. When you chew, that joint moves and it pushes against the inflamed skin. It's excruciating for them.
That is a great clinical pearl. So let's move to the physical exam. The ouch test. What's the standard here?
The quickest way to spot this, and the guidelines call this out as the key diagnostic sign, is tenderness over the tragus or the pinna.
The tragus being that little nub of cartilage in front of the opening.
That's the one. You give it a gentle push, or you pull up and back on the pinna, and the patient practically jumps off the couch.
And that helps tell it apart from otitis media.
Correct. With otitis media, the infection is deep behind the drum. Wiggling the outer ear doesn't really hurt. But with otitis externa, you are physically moving the inflamed skin itself.
And when you actually look inside with the otoscope,
You're looking for a narrow, angry, red ear canal, swelling, maybe some cheesy discharge. Sometimes the canal is so swollen you can't even see the drum. It just looks like a closed fist.
okay, so we've got the diagnosis locked in. But before we get to the scripts, I have to talk about why this happens. We have to do the cotton bed rant.
Oh, we absolutely have to. It is the bane of every GP's existence. The guidelines specifically list local trauma as a major risk factor, and they call out cotton buds by name.
It's credible, isn't it? People think they're cleaning their ears.
I know, but the ear is a self-cleaning oven. It pushes wax out naturally. When you stick a cotton bud in there, you're just pushing wax back down, and more importantly, you are microabrading the skin. You're scratching the barrier.
Creating an open door for infection.
Exactly. And the skin in there is so thin, you stick a cotton bud or keys, yes, the guidelines mention keys or earplugs in there, and you're just inviting Pseudomonas and staph to the party.
Keys. Wow.
You would be surprised.
But it's not just trauma, is it? Moisture is the other big one. Hence, swimmer's ear.
Right. Swimming is a massive risk factor. Water washes away the protective earwax, which is actually slightly acidic and antibacterial. Plus, it just macerates the skin. It gets boggy, the pH rises, and bacteria just love that.
Are there any underlying conditions we should look out for?
Yeah, skin conditions play a huge role. If a patient has eczema, psoriasis, seborrheic dermatitis, they're just predisposed. Their skin barrier is already compromised.
So, part of our job is prevention. What should we be telling these patients so they don't come back?
The golden rule is keep the ears clean and dry. But clean doesn't mean scrubbing. For showering, the guidelines have a really practical tip. Use cotton wool coated in petroleum jelly.
Like a little homemade waterproof plug.
Exactly. Roll a ball of cotton wool in Vaseline, pop it in the outer bowl of the ear, and it keeps the soap and shampoo out. Soap is an irritant, changes the pH.
That's a great tip. I also saw something about hair dryers.
Yes, this is one of my favorites. If the ear does get wet, do not use a towel. Use a hairdryer on the lowest heat setting. Hold it at arm's length and just let the warm air gently dry the canal. No sticking anything in there.
Brilliant. And for the swimmers?
For them, prophylaxis is key. The guidelines mention acetic acid or alcohol-based sprays, brands like Ear Calm or Dry Ears. They help dry the canal, and crucially, they acidify it. Pseudomonas hates acid.
Okay, let's get to the main event. Treatment. The patient is in pain. We've told them to throw out the cotton buds. What are we prescribing?
Well, the first thing to remember is that oral antibiotics are rarely the answer here. The infection is superficial, so we want to treat it topically with drops.
Drops are the gold standard.
Yeah.
But there's a huge fork in the road here, isn't there? It all depends on one thing.
This is the most critical decision point you have to ask. Is the tympanic membrane intact or is it perforated?
So let's do scenario A. You can see the drum, it's intact. What's the first line?
The standard approach is a topical antibiotic combined with a corticosteroid. The antibiotic kills the bug. The steroid brings down the swelling and pain.
And what are the specific drugs?
You've got gentasone HC, which is gentamicin plus hydrocortisone. There's Sofradex framicetin, gramicidin, and dexamethasone, or betamethasone N, which is betamethasone, and neomycin.
So mostly amidoglycosides with a steroid. And the dosing.
Typically 2 to 4 drops every 6 to 8 hours for about 3 to 7 days, depending on response.
I noticed a very real-world note in the guidelines about supply chains.
Yes, that is a nod to reality. Eardrops go out of stock all the time. The guidelines advise writing state a suitable alternative on the prescription. Just saves the pharmacist having to call you.
Good advice. Okay, now scenario B. This is where it gets dangerous.
Yeah.
The drum is perforated or you just can't see it.
This is a massive patient safety issue. The aminoglycoside antibiotics we just mentioned, gentamicin, neomycin, frenicidin, are potentially ototoxic.
Meaning they can damage the ear.
Yeah. Specifically, they can damage the cochlea and vestibular system. If those drops get through a perforation into the middle ear, they can cause permanent hearing loss or chronic dizziness.
So if there's a hole in the drum, all those first-line drugs are completely off the table.
Completely. It is non-negotiable. If there's a perforation or a grommet, you must avoid them.
So what's the safe alternative?
We use quinolones. Specifically, the guidelines recommend ciprofloxacin drops. They are not ototoxic. Dosing is a bit different, usually 4 drops every 12 hours for 7 days.
That's a crucial distinction. Perforation equals ciprofloxacin. Intact equals aminoglycosides.
It is. And if you aren't sure if the canal is too swollen to see the drummer on the side of caution, treat it as a perforation. Don't gamble with someone's hearing.
What about really mild cases? Do we always need antibiotics?
Not always, no. If it's just a bit itchy and red, the guidelines mention acetic acid, like ear calm spray. It's an antiseptic, creates that hostile, acidic environment. Often that's enough.
And we shouldn't forget simple pain relief.
Never. This condition hurts. Always advise regular paracetamol or ibuprofen. Treat the patient's misery, not just the bug.
Okay, so we've picked the right drug. But here's where it gets interesting. The guidelines mention that treatment failure is common, but often not because of resistant bacteria.
Right. This is the secret sauce of this deep dive. The guidelines state, a common cause of treatment failure is underdosing due to technique of application.
Which is a polite way of saying patients are doing it wrong.
It is, but it's because we don't teach them properly. Most people stand up, tilt their head for 5 seconds, squeeze a drop in, and then stand up straight.
And the drop just runs right out.
Exactly. It never gets past the swelling to where the infection actually is.
So walk us through the correct method. What should we be teaching?
Step 1, clear the way. Gently remove any visible discharge. Then step 2, lie down. Not just tilt your head lie flat with the affected ear facing the ceiling.
Okay.
Step 3 is the pump. This is the bit everyone misses. You fill the canal with drops, then you gently push and pull the tragus.
Why are we doing that?
Think of it like a test tube. If you just drop liquid on top, you can trap an air bubble at the bottom, an airlock. The liquid never touches the skin deep down. Pumping the tragus burps that air out and lets the medicine sink in.
The airlock. That's a great visual. I'd never thought of that.
And then step 4. The patient needs to stay in that position for 5 minutes.
5 minutes? That feels like an eternity to most people.
I know. It's a hard sell, but it is necessary. If they can't stay still, the guidelines suggest a cotton plug moistened with the drops to keep it in place. But honestly, the lie down and pump technique is what cures the ear.
That phrase, underdosing due to technique, is so powerful because it's so fixable.
Absolutely. It's not about a stronger drug. It's about better delivery.
So we've treated them. We've taught them the pump technique. Let's talk safety netting. When should we worry?
We advise the patient to return if there is no improvement within 48 to 72 hours.
And if they do come back?
Then you need to rethink. Is it a resistant organism? Is it fungal? You might need to take an ear swab for culture. Or they might need a referral for microsuction, what we call oral toilet.
Can you explain oral toilet?
It's basically vacuuming the ear. We use a microscope and a tiny suction tube to clean out all the debris and dead skin. Sometimes drops just can't work until you've physically cleaned the canal.
Okay, and let's just quickly reiterate the danger signs for malignant otitis externa.
This is the danger zone. Unrelenting pain that keeps them awake at night, especially pain that extends down into the neck or deep into the jaw.
Or if they look systemically unwell.
Yes, fevers, rigors. But the absolute critical sign is cranial nerve involvement. If you see a facial palsy one side of the face drooping, that's a red alert.
Because the infection has moved to the bone.
And is compressing the facial nerve. That is an urgent, same-day referral to ENT. No messing about.
And just to close the loop, if it drags on for months.
Greater than 3 months, it's defined as chronic otitis externa. And that's a whole different conversation.
So let's summarize. We've got the don't stop sticking things in your ears.
Please, just stop.
We have the dose gentasone or Sofradex for intact ears, ciprofloxacin for perforations, or if you're not sure.
Correct. Always protect the cochlea.
And we have the how lie down, pump to break the airlock, and the 5-minute rule.
That is the trifecta.
It's fascinating. We spend so much time worrying about antibiotic resistance, but sometimes the solution is purely mechanical.
And that's the final thought I'd leave everyone with. When we see a treatment failure, our instinct is to escalate. We think, oh, the drops didn't work, let's give oral antibiotics.
Which drives resistance and has side effects.
Exactly. We rush to prescribe stronger drugs for what we think is a resistant infection. But in reality, the cure was sitting in that little bottle the whole time. It just never actually reached the bottom of the ear canal because the patient stood up too fast.
How many courses of oral antibiotics could we save just by teaching that 5-minute rule?
I think quite a few. It's about taking that extra minute to explain the how, not just scribbling the what.
A powerful thought to end on. Thank you for joining us on this deep dive into the HSE guidelines.
It has been a pleasure. Keep those ears dry.
See you next time.
Please don't forget to hit the like and subscribe for more educational videos like this.